what I'm going to do actually is just quickly remind you about why we need to improve the care of patients with sepsis. Of course, we've heard some very good talks already about that. I'm actually only going to give a very sort of brief, broad discussion about the role of education and training, and I'm going to spend most of the time talking about simulation. And then I'm going to show you some simulation. I'm going to ask you to critique it, which hopefully you'll enjoy. So we've heard already that there are lots of very good reasons for trying to improve the care of patients with sepsis. We know this is a very significant condition. We know that the mortality rate for this condition may be as high as 40 or even 50% for patients with septic shock. We know it's incredibly costly. It's conservatively estimated in England that looking after these patients may cost about £20,000 per patient. We know too, and we've heard from Jane this afternoon, of the horrible physical and psychological trauma that survivors of this terrible condition have to endure. And most worryingly of all, we know that this condition is increasing. It's becoming increasingly common. And in our country alone, maybe around 2,000 or so patients die from this condition every year. And are we good at it? Well, we're not. We know that. And many of you in the audience will be aware of this poor lad. This is William Mead, who was a 12-month-old who sadly died from septic shock, despite there being lots of opportunities for NHS Direct and the general practitioner to intercept and treat this boy properly. And his care was so abysmal that it prompted this admission from Mr. Hunt in the English Parliament, who said, quite incredibly, that actually the NHS is totally inadequate at stopping sepsis. And we've got very good objective evidence, and I'm sure Paul may have alluded to this. This was the report from NCPOD, which was published a couple of years ago, showing that in nearly 2/3 of cases, the care that we gave these patients was suboptimal. So there are good reasons for trying to improve this care. And frustratingly, in the NHS, we know fine well what good quality care looks like. It's not difficult. We know that if we were providing high quality care to patients with sepsis, it would be timely, it would be safe. Self-evidently, the interventions that we need to use to control the source of sepsis, to improve their outcomes, shouldn't cause any harm. We know that the care should be effective and efficient and patient-centred and equitable. We know that fine well. And so what really supports high-quality sepsis care? Well, I guess there are two main pillars, if you like, that support high-quality care in anything. Firstly, and from my point of view, most importantly, very high-quality education and training. It's self-evident, surely, that if you want to provide high-quality care, then your providers must know about the condition. They must understand the condition. They must understand its epidemiology, its pathophysiology, how it presents and how it's treated. That's surely self-evident. And then the other pillar of high-quality sepsis care is continuous improvement. And actually, continuous improvement and education and training, they're almost two sides of the same coin. There's a lot of overlap there. At a very simple level, to do good quality improvement work, you need to understand the methodologies and you need to be educated about them. So I'm going to talk about education and training, and I'm just going to tell you what I think are some of the key principles here. Firstly, that your education and training has to be linked to clinical governance. That link has to be incredibly strong. It's not merely about the punitive side of governance, examining things when they go wrong, doing root cause analysis and learning from mistakes, but it's also about putting remedial training in place, and it's also about actually sharing good practice. As Matt alluded to, you have to have good evidence for the concepts that you're promoting. And there's a real danger when evidence is lacking, but there's great public concern, that you put things in place that actually have a very flimsy evidence base. So it has to be evidence-based. Probably the most important thing about education and training is it has to be multidisciplinary. It absolutely has to be. And what's so interesting about this is Firstly, patients with sepsis will present to lots of different healthcare providers in lots of different areas, but actually, ultimately, it takes a team of healthcare professionals to make these patients better. And it seems ridiculous, actually, that we don't frequently and always train together to provide optimal care. Training has to be accessible, and that's a huge problem. We're all extremely busy clinicians, we all have lots of service demands, and trying to make the time for training is very difficult. But we have to do that. And there are ways of doing it that are quite simple. Simple things like when you're looking after a patient with infection or sepsis, and you're looking after that patient with junior colleagues or nursing colleagues, actually just telling people, taking the time to explain what you're doing and why you're doing, is actually training. Of course, we can do more subtle things. We can actually bring training into the workplace, and we'll talk a little bit about that when we talk about simulation. You have to have a lifelong sort of career-long, if you like, attitude to learning, and you constantly need to recycle training so that there's constant repetition and reinforcement. We've heard from Jane today, and as I say, it's an incredibly moving account, but absolutely it has to be based on a strong patient voice in this. What is really important? I learned from Jane today that actually services in the community, when I discharge patients from the critical care, are not very good. She's done very well because she's so self-motivated, but there are others who go into the community, and I've learned today that the care and support for them is not good. So you need a patient voice. And probably also very importantly, you need to be very balanced. There's lots and lots of issues confronting the NHS. How do you look after patients with diabetes, hypertension, chronic obstructive pulmonary disease? How do you provide good service? And what you've got to do is have a balanced approach. You can't use scarce resources in areas where there's a large public outcry, but actually not a large public health need. So you have to be very balanced. And so there's some good news here, and the good news is there's two critical ingredients that we're not short of when it comes to education and training. The first ingredient is that we have a great hunger in the NHS to learn. The very fact that this lecture theatre is almost full is testament to the fact that people want to get better and they want to learn. That's the first thing that you need. And then the second thing you need is providers. And we have an abundance of educational providers. We've got the big hitters, the deanery, the university, the UHB, professional societies, royal colleges, and all the rest of it. We've got no shortage of fantastic educational material. You only have to go online to realise that the educational material that we have in our generation so far surpasses what perhaps Paul and I had 20 or 30 years ago as not to be true. So there's no shortage of the crucial ingredients. So it comes down to, in my mind, three things that you absolutely need to bring those things together. The first thing is you need an absolute spirit of cooperation. It is ridiculous to be learning in different silos. It's ridiculous to be doing work and duplicating work across different departments, different silos, different bodies. Wherever possible, you need to collaborate and cooperate. It's an issue about signposting. Often it's just about telling people where the education and training is. It's about an imaginative use of social media to do that. And as I say, you do need to plug this in to a very good sort of corporate governance structure that will enhance the education and training. So I just wanted to talk to you about the magic and alchemy of education, because it is quite staggering. If you look at this slide, on the left-hand side of the slide, or my left at least, you'll see there's a group of 5 very bright, enthusiastic sixth formers. And our process in our school, duplicated throughout all the medical schools in England and Wales and Scotland, is to take those sixth formers, put them through a curriculum, and at the end, generate a doctor or a nurse or a physio in which the public will be happy to put their lives. What an incredible process. What a testament to the fact that in our country, year on year, we churn out thousands of these healthcare professionals. I wanted just to tell you a little bit about the magic of the curriculum, which is a spiral curriculum. And that goes back to curriculum design that's been known about the spiral curriculum for many, many years. And it's the notion that what you do with these people is that you allow them to revisit themes consistently as they progress through training. So you allow them to build on their previous experience so that they can take relatively simple concepts and ideas and ultimately develop the skills and attitudes and knowledge that they require to be high-functioning healthcare professionals. And so in terms of sepsis in our School of Medicine, our students will, in the first years of their course, they will study the relevant immunology, the microbiology, the pathology. And then as they progress to the middle parts of the course, they will be seeing patients with infection and sepsis and maybe revisiting those basic themes. And then finally, in the final year of the course, they will be in the workplace, either in general practice or on the wards, seeing patients with infection and sepsis all the time. And so, without getting into the difficulty of curriculum design and delivery, you're taking someone from being a novice to at least competent or probably proficient, and there are lots and lots of ways of doing that. And what I wanted to spend most of my time on is actually just talking about simulation, because I think it is an absolutely fantastic way of delivering training. Now, simulation has been around for, maybe the last 20 years or so. It's absolutely really taken off. As I say, when I was a medical student, obviously many, many years ago now, but when I was a medical student, you didn't see this at all. The ethos was you saw something, you did it, and then you taught it. And that caused quite a lot of harm, actually, to patients. But now we have, learned associations around simulation, national associations, we have journals, we have a tremendous explosion in this. I think the thing that I would say, however, at the outset of saying I'm a big enthusiast for this training is that it should be seen as an adjunctive to direct clinical experience. It's not there to replace it, it's there to support it. It's an adjunctive. So, the advantages are huge. You have essentially the ability to practice risk-free medicine. You don't see mannequins complain very much when they're abused or the wrong things are done. You can be very flexible. You can provide this sort of training in the workplace. You can explore error. You can explore error in a way which you could never do in a real clinical scenario. So if a person is making a mistake, then you can follow through the natural history of that mistake, even if the mannequin has a cardiac arrest or deteriorates. You can explore relatively rare and unusual presentations which trainees may not often see. It's very reproducible. The advantages go on. You can practice invasive procedures, you can use real equipment, you can interrupt a simulation at any point to correct behaviours. You can record and replay the episode. And most of all, you can do very good performance evaluation, particularly of how the trainee or how the student is interacting with other members of the team, as well as their technical skills. So it's got lots and lots of advantages. Now, in Cardiff, as I say, and actually throughout Wales, we've been doing this sort of training for some years now, and it generally conforms to sort of 4 phases, really. The first phase is you give a brief to the student or the delegate. The student then progresses and goes into the simulation laboratory and sees the patient and performs a sort of ABCD type assessment. And whilst that's happening, his peers or her peers are watching that remotely, and then everybody gets together for a debrief. And that sort of training is actually very well received, and we've evaluated it repeatedly over the years, and generally students like this very much. And so rather than sort of talk endlessly about it, on the basis of pictures worth 1,000 words, what I thought I'd do next is show you a simulation. I'm going to show you a simulation which is performed by some of my colleagues who are in the audience. I have to be very, very careful about how I phrase this. The people doing this simulation are fantastic. They're very, very good and experienced clinicians. That's the nurses. The doctor doing the simulation is also fantastic, but is a relatively junior trainee. The simulation results or leads to a number of very significant errors. And your task is to, in the light of what you all know about sepsis, is to identify those errors. Okay? So I'm going to play you the simulation now. And what I'd like you to do is, in the light of all of your knowledge, identify the deliberate mistakes that my colleagues make. Who'd like to start the ball rolling? Do you think that's a flawless performance? Okay. Any obvious and deliberate errors?
Just about in the APE assessment, quite a lot.
Yeah, a little bit of, yeah, you'd have to say it didn't really conform to the nice sort of laminar flow of an ABCD type assessment, fair enough. Were there any more sort of critical errors, actually?
I didn't hear it mention arterial blood gas or lactate.
A lactate was mentioned. It was a venous lactate, in fairness, but well done for trying that one. She did actually mention that. Anything else?
Did she ask for an FBC?
She might have done, yeah.
It was a VBG they asked for, not
They asked for venous blood gas, yeah. What, in the context of sepsis, what was the sort of more worrying? Blood cultures were being done through the cannula. Very well spotted, Jane. Anything else? Okay, I'm going to put you out of your misery. I think there were a number of cardinal errors, actually. The first of these was actually, although antibiotics were talked about, and there's a great store that we're going to give Tazazin. In fact, when the junior doctor spoke to the ICU doctor, said that Tazazin had been given. At no point was the antibiotic actually prescribed or given. And that's a common problem. There seems to be, just because I've said we're going to give antibiotics, somehow that means it's actually happened. So at no point in that simulation was the antibiotic actually given. You probably may or may not have spotted, it was actually not that easy to see, that the oxygen mask, the reservoir bag wasn't inflated, and therefore actually the patient wasn't really getting any oxygen. The clinical examination, from a sort of MRCP perspective, would be a little bit suspect. Both sides of the chest weren't examined, and the consultant appallingly showed, the usual poor hygiene. He neither gelled his hands before or after contact with the patient. So I hope you kind of see that it's actually quite a powerful way of delivering good quality education and training. So just to finish, I'd like to tell you where we are currently and where I think we need to go with this sort of training. So the first thing to say is that simulation training is embedded within the curriculum of the School of Medicine, and it's delivered exceptionally well actually in centres throughout Wales. Since really 2007, maybe 2008, these simulations have formed part of the sort of summative final assessment of our students. And in fact, that's been commended as being good practice by the GMC, and we're sharing that practice with other institutions. We always try and encourage an interprofessional learning, a multidisciplinary approach. And so typically in those sessions, they would be attended by student nurses and on occasion student pharmacists as well. And most recently, over the last 12 months, in fact, this sort of training has been incorporated into postgraduate training, being the quality improvement service training that was funded by the Welsh Deanery, and we put about 60 or 70 of our colleagues from Cardiff and Vale UHB through that training, and that was generally well received. And of course, it's been part of our All Wales Acute Care and Simulation Teaching Symposium, which we've held now for the last 4 years. Where I think we need to go with this, firstly, as I said earlier, I think this is all about collaboration, and we absolutely have to, within the College of Biomedical and Life Sciences, break down the silos. We have to routinely get more students from the School of Nursing, the School of Medicine, Pharmacy and Physio and so forth, all working and training together, and that absolutely is happening. We absolutely have to increase collaboration in the postgraduate environment. As I say, it's kind of ridiculous to have these silos of activity happening all the way. It's wasteful, it's inefficient, and we need, wherever possible, to bring this training together. We absolutely have to continue to try and integrate training with clinical governance. It's just such a nice, responsive way to respond to problems if you can offer remedial training along these lines. I think it makes perfect sense to do that. And as Matt said earlier in his talk, we really need to start seeking evidence, because at this stage at least, despite 20 years of activity around simulation, the actual hard evidence that it improves clinical outcomes is still to be found wanting. And so on that note, I'll finish, and thank you very much for your attention.